Okay, good morning, everyone. The appointed hour is here, so why don't we go ahead and get started. I want to welcome all of you here in the conference room and those who are watching live to this program we have this morning. My name is Jim Capretta. I'm a resident fellow here at the American Enterprise Institute. And along with my colleague Joe Antos, I want to thank the speakers who will participate in the program, who have agreed to come this morning and share their thoughts, with special thanks to Congressman Bruce Westerman for agreeing to come and share his ideas with us. I will turn over the podium here in just a minute to my friend Ovik Roy, who will introduce the Congressman. But I want to take a moment, because that's what we do here at AEI, to of course give my thoughts first, about what we're doing here this morning and why. It's been almost 10 years since the Affordable Care Act was enacted. Over the past decade, the two parties have engaged in a near continuous debate, and that's putting it politely, over the merits of the law. The GOP tried, after President Trump assumed office, to repeal and replace the ACA, but of course failed. As we head into 2020, and the election that will take place just over a year from now, both parties are having to recalibrate their healthcare agendas in light of what's occurred over the last decade and the debate that took place, as well as on-the-ground realities about what's actually happening with insurance enrollment, coverage, costs, and other factors that are affecting Americans and their use of services. The ACA remains in effect. The law is there and it's working, and in some ways as intended, but it's clear it wasn't a panacea. There's still a lot of upset about the healthcare system in many different dimensions, insurance enrollment as well as costs and the pressures associated with it. The tendency of both parties is to gravitate toward ideas that fit comfortably within a fixed ideological point of view about what should happen over the long run with the health system. But in my judgment, and I could be wrong about this, but my judgment is that the American health system is a vast, entrenched system with significant roles for both the public and the private sectors. And I think it's very unlikely, given how big and complex and entrenched this system is, that it's going to move hard one direction or another. That is, it's not going to move entirely toward a publicly run system, or one with very little role for private initiative or private sector institutions. Nor do I think it's going to go entirely in a market sort of direction without a lot of public role in terms of subsidization and regulation. In other words, I think we're stuck with this big, complex, messy public-private system. Therefore, I'm interested in ideas that try to take this as a given and use that as a starting point for figuring out how to make it better, work better, operate better, serve the public better. I don't want to speak for the Congressman, but I see his plan that we'll hear about in a few minutes as fitting in with this general overall perspective. It's try to be a little more practical about where do we go from here given the realities that exist on the ground. So I think he deserves a lot of credit for coming forward with an idea that breaks free a little bit from the decade-long debate that we've had over the ACA and its merits. After we hear from the Congressman, Joe Antos, my AEI colleague, will moderate a panel that I'll participate in, where we will dive a little more deeply into what's going on the campaign trail, what plans are being put forward, what are the implications of them, and what are the politics around them. So we'll hear about that toward the end of our program. But first we'll hear from the Congressman. And let me introduce Ovik, who will take a few minutes to introduce the Congressman. Ovik Roy is the president and founder of the Foundation for Research on Equal Opportunity, a think tank devoted to promoting economic policies that are beneficial to all Americans, most especially for those who currently have the least resources. He received a medical degree from Yale and spent several years examining companies in the biopharma space for Bain Capital on Wall Street, so he knows that industry very well. He's a very active participant in ongoing health care debates on a number of dimensions, including pricing for prescription drugs, and he concurrently serves as editor of Forbes' opinion online pieces. So without further ado, thank you, Ovik, for coming. Thank you.
Thanks, Jim, and thanks to all of you for being here. It's my pleasure to introduce Congressman Bruce Westerman to you this morning. I first got to know the Congressman when he was Majority Leader of the Arkansas State House of Representatives. I was traveling the country briefing state legislatures on the ACA's Medicaid expansion and on the decisions that they had to make with regards to that topic. And when Tom Cotton went on to the Senate from the House of Representatives, now Congressman Westerman ran for Tom Cotton's old seat and now represents that district. He's now a third-term congressman. I can tell you he was a defensive back for the Arkansas Razorbacks, so if you like college football, you can ask him your questions about defensive strategy on that side of things. And his son is a graduate of Yale College. I got to know his son because his son was a member of the Conservative Party of the Yale Political Union, which I chaired, I won't tell you how many years ago. As I got to know the congressman, one thing that has struck me, and I think you'll hear this today, is that there are a lot of people, a lot of members of Congress who really care about getting in front of the cameras, about getting the press release, getting that attention, being able to show that they stand for X and having that associated with their name. This congressman is very much a workhorse, not a show horse. He's a guy who really has been putting his head down, trying to work hard and take on very tough problems in ways that can actually pass the test of getting 60 votes in the Senate and getting bipartisan support. And I think those of us in the think tank world who've gotten to work with him on this project of trying to develop health reforms that can work for all Americans have really enjoyed that process. So without further ado, let me invite Congressman Westerman to the stage to give us some opening remarks.
Thank you, Ovick. Thank you, Ovick. Thank you, Jim and Joe and everyone for being here today. This is quite an honor to me to get to come to AEI and make remarks. I got to know Arthur Brooks quite well. He used to come over to the Capitol once a month. Kevin McCarthy would have him over and have a small group of us meet with him in his office, and he was going through the material he had researched to do his new book, Love Your Enemies. And I got to kind of, I guess I was the guinea pig or the lab rat, getting to hear how his research was working there and getting to visit with him about some of the in-depth things that he worked on to put his new book together. And earlier this summer, I got a call from a constituent of mine, an older gentleman, and he just said, you have to read this new book. It's called Love Your Enemies by Arthur Brooks. Have you ever heard of it? And I looked over and my copy of the book was on my desk, and as busy as we are serving in Congress, it's hard to find time to read anything for pleasure. But to have a guy back home call me and say, you have to read this. He actually said it should be mandatory reading for everybody that serves in Congress. So I started reading the book and I could hardly put it down. And I think what Arthur captured in that book speaks a lot to why we're having so much of big issues with health care in D.C. today. He talks about the contemptuous attitude that's permeating through Washington, D.C. and the federal government, and how as long as we keep that contemptuous attitude, it's not going to be good for policy, it's not going to be good for the country. And I think there's probably no issue that we've seen more contempt than in the issue of health care. So it was very fitting that Arthur wrote that book and that my constituent encouraged me to read it at the time that he did as we were working on this bill. My staff always tells me you've got to tell people your social media account, so if you want to find out anything more about me or the bill, you can go to @RepWesterman on Facebook and Instagram and Twitter and all that good stuff. To lead off today, I want to tell you a little bit about why I'm interested in healthcare. Ovick mentioned that he worked with me some when I was the majority leader in the Arkansas legislatures. We waded through the Affordable Care Act, and I learned firsthand what federal policy does to states. We all think of the ACA as federal policy, but it was a huge job just implementing that policy on the state level, everything from the exchanges to the Medicaid expansion and the huge domino effect that it had all across the country when a major law like that gets implemented. So I worked through that, got here to Congress, but we all, I think, have a healthcare story that's affected us in life. Ovick mentioned my son Eli in his remarks. When Eli was 1 month old, he had a cold, we thought. We took him to the doctor. They immediately put him in the hospital. He had RSV, a viral infection, which most kids get it, but the younger you are, the worse it is. And he just wasn't getting any better. They had him in the little plastic bubble giving him breathing treatments. And the doctor came to us and said, there's this new antiviral drug. It's $5,000 a dose. He needs five doses of it, but your insurance doesn't cover it. What do you want us to do? Well, she could have said it's $50,000 a dose or $100,000 per dose. If we think it's what's going to make our child well, we'll worry about how to pay for it later. So he got the antiviral drug. He got better, and he graduated from college a year or so ago. And it's a great testament to the innovation and the quality of healthcare that we have here in America where that drug was available. We paid for it, we moved on with life, and that's the way it goes. But people face choices like that they have to make every day. And I can tell you, when you're in a situation like that, you're not thinking about supply and demand or price, you think about price, but there's not really another option that you have. Also, from my business experience, I was a partner in an engineering firm for over 2 decades before I came to Congress, a small business, and every year we got bids on our insurance policy. And every single year that those bids went up, and they went up much higher than the rate of inflation. And if we happened to have someone in our group policy that had a severe illness, the policy would go up a whole lot more the next year. And small businesses are facing that all across the country still today. And not only would the policy go up, the premiums would increase, the benefits would go down, the deductible would go up, and it's a situation that Americans find themselves in every day. It doesn't matter if you're healthy, sick, young, or old. Health care affects every single American, and it will affect you at some point in your life. Health care consistently polls for most Americans as a top area of concern. It accounts for nearly 1/5 of the U.S. economy and 1/4 of federal spending. It's driving our deficit problems with no end in sight. But these costs aren't market-driven. They stem from decades of government involvement in the market through regulations and rules, and were exacerbated in 2010 by the enactment of the Affordable Care Act. For example, in just the last 10 years, insurance deductibles have tripled for people with employer-sponsored insurance. Coupled with high monthly premiums, Americans are spending more and more of their paychecks on health care when that money could be better spent, saved, or put into retirement accounts. In fact, the average American spends roughly 14.5% of their take-home pay on health care. This is simply not sustainable. Instead of setting aside and waiting for the next health care bill to be proposed, or worse yet, have a public option or a single-payer system to take hold, I began compiling a list of reforms that I think both the left and the right can support. And my legislation that we're going to talk about today, the Fair Care Act, or H.R. 1332, it has 2 primary goals: increase the number of people that are covered and lower the per capita cost for those who are being covered. I address public and private payers, drug prices, provider competition, as well as healthcare innovation. We can do this. When you start looking at the magnitude of healthcare and the complexity of it, it seems like an overwhelming problem. But I can tell you that as you get into the individual issues and start looking at what's the best thing to do, what are the best ideas out there, it's something that we can do that's attainable, but it's going to require bipartisan support. And, I recognize this, having gone through implementing the ACA from a state level, seeing the contentions in Congress around health care, and quite frankly, neither party's been able to do it on their own. The Democrats gave us the Affordable Care Act. They did it on party line votes. They had 60 members in the Senate. They were able to get past the filibuster when they first passed the ACA. And then we tried to do the AHCA a couple of years ago, and it failed by one vote in the Senate. Nobody has the market cornered on good ideas on health care. So our objective was to find the best ideas for health care and implement those ideas. We didn't screen them to see if they're Republican ideas or Democratic ideas, but what are logical, reasonable ideas that will make health care better in this country. And that's what you have in the Fair Care Act, is a compilation of those ideas. We would create a guaranteed protective pool program that helps pay for the highest risk individuals. It allows insurers to charge less for private insurance coverage. I remember as I was in the state legislature learning more about health care, I met with a former executive of Walmart who talked about how they addressed the health care issues within their obviously very large company. And they said that the numbers were something like 10% of the people account for 85 to 90% of the cost. And they said health insurance for so long had focused on the 80 to 90% of the healthy people, where all the costs were in the 10% people. And they really started focusing on how to deliver better health care for those 10% who were creating most of the cost of health care. And what they found were there were a lot of people who would get misdiagnoses on very serious diseases, so they would always go get a second opinion, and they might take an employee on a corporate airplane to the Mayo Clinic or some other center of excellence so they could get a second opinion from experts in the field. And they found by focusing on how to deal with the high cost in the areas where most of the costs were, they were able to lower their healthcare costs. Well, this is really kind of the idea of a guaranteed risk pool. You take the sickest individuals and you cover their cost through a risk pool, and you're still spending government money, but you're doing it in a more effective and sensible way than some of the programs that we have now. We continue to cover patients with pre-existing conditions, and we allow consumers to shop for coverage across state lines. We reinstate the 5-to-1 ratio on the age band. I think what we've got in the bill goes a long way towards creating solvency for Medicaid and Medicare. I've served on the budget committee, and Medicaid it's the endless pit of money, and that's how the states see it. I've heard more times than not, it's free money from DC. And there's no limit on how much you can spend on Medicaid. However much the state spends, the federal government matches that. And that's why you get these crazy things like provider taxes, where a state taxes itself because the percentage of the tax they pay, they get a matching rate from the federal government to help pay that tax. It makes absolutely no sense to do that. So Medicaid's not really in danger of defaulting, but it just continues to grow at terrific amounts of cost each year because there's no limits on how much you can spend on Medicaid. Medicare, on the other hand, the CBO tells us it's on a path to insolvency. They keep adjusting the dates, like 2030, and Social Security's right there with it. We're not talking about Social Security here, but many of these programs that are driving the debt and the deficit are unsustainable. So we need to do something to make these programs sustainable over the long run, and we address that. Number one, by moving Medicaid back to what it was intended for, the aged, the blind, and the disabled. And there's a better way to provide care to low-income individuals. I think we can do that through the individual marketplace, but we have to get a robust individual marketplace so that there's more competition on it. We give states more opportunities to design health care programs that meet the unique needs of their population. We would clear red tape that limits the entrance of generic and biosimilar drugs into the market and make experimental new drugs more accessible for patients with severe illness. I've already co-sponsored a bill with a Democratic rep from Illinois on reducing the exclusivity period for biosimilar products. There's the CREATES Act was something that Senator Leahy had in the Senate. So we're bringing in Republican and Democratic ideas, and we've got those encapsulated in the bill. We break up hospital monopolies and insurance monopolies. That's one of the big problems, I think, with driving up cost is monopolistic systems, whether it's in hospital providers, mainly in urban areas. We do try to help hospitals in rural areas because in districts like where I live, you may be 30 or 40 miles to one hospital, and that's your only option. You take that away and you're 50 to 100 miles away from a hospital. So you can't just paint with a broad brush with a country as big and diverse as ours, because it really causes disruptions and doesn't lead to good outcomes. We encourage the use of innovative technologies like telemedicine to help provide high quality care to even the most rural Americans. After introducing the Fair Care Act last February, we couldn't have probably picked better timing because we introduced it a couple of weeks before President Trump came out and said we were going to start working on health care again, and Republicans were going to be the party of health care. I think the national media looked across the board and said, well, Republicans don't even have a plan, and they said, who's this guy Westerman that's not on Energy and Commerce or Ways and Means? He's some engineer and forestry guy, and he's got this big health care bill out. So I got to talk a lot about the Fair Care Act. I've visited with a lot of my colleagues. There's a lot of interest on Capitol Hill about the Fair Care Act. And from that, we've gained more ideas and more things to put into it. We're going to introduce a new version. We actually had hoped to roll out Fair Care Act 2.0 around this particular meeting today, but Legislative Council is not on the same timeline that we're on, so we're still working on it, which is a good thing because we're getting even some additional ideas. We're going to expand on the ability for consumers and beneficiaries to choose what healthcare options work best for them. We're going to allow health savings accounts to be used for direct primary care and individual market insurance. I know a lot of people have talked about that, but the first time I heard about using HSAs for direct primary care was from a provider back home in Arkansas. And I find that just by talking to people in the healthcare field, I get the best information out there by going home and talking to people that know healthcare. I had a great meeting last week with an independent pharmacist who had charts and data and was showing me how that what's happening with PBMs and how that if this keeps up, you're not going to have independent pharmacists, that they're literally going to be put out of business with the way the system's arranged right now. So it's always good to go back and talk to people. I've had meetings with physicians groups. I met with the head of Arkansas Blue Cross and Blue Shield, and they like the idea of what we've got. And what you're going to see is, we'll never agree on everything, but I think this is a great starting point to come together on ideas. And I think America realizes that we can do a better job, and people are willing to give some things up to get stability and to get a good plan going forward. And we'll never come up with a health care bill that everybody agrees 100% on. But I do think we've got a great framework here that we can build on, that it can gain bipartisan support. I've had Democratic members come in my office and go through the bill, and they'll be like Republican members that come in my office and go through the bill. I really like this. I'm not sure about this part, but those are the kind of conversations that we need to have, and it needs to be an open and honest dialogue on what is best for Americans, what's best for the consumer, what's going to give us the best health care and move us down the road in the right direction, so that someday health care is not the topic that's dominating discussions on federal policy. We can move on to other things. And if we get health care right, we can do more to address the debt and the deficit than probably anything else that we do. It's that important of an issue, and that's why, even though I'm not on the authorizing committees and I don't have a background in health care, It's extremely important, and that's why I've put so much time into it, why I've had my staff put so much time into it, why we've worked with people like Ovic that can get really, really deep in the weeds, and why we want to work with everybody in the room to come up with the absolute best ideas to make healthcare in America the leading healthcare system in the world and make it far above all the rest, and not go down the road of copying what the rest of the world's done and think that's what's going to be better for the United States. So again, it's a pleasure to be here. I look forward to having a chat with Ovic, and I don't know if we're going to do question and answers, but it'll be good however we do it. So thank you for your time, and great to be here.
Well, first of all, let me say thank you for being here, and thanks for all the hard work on this plan. For those of you who haven't gone through the text of the legislation or even the section-by-section summary, we at my institution have put out a brief summary of the plan, which is, if you're in the room, it's on your tables, and for those of you watching online, we will be posting that summary of the bill online at our website, freopp.org. That's freopp.org. I want to spend some time on the policy, and then maybe we'll talk about the politics of health reform and your bill. Starting with the policy, I mean, it's a pretty impressive bill. I mean, what you've tried to do is you're trying to expand coverage and reduce federal spending at the same time, something that a lot of people either have given up on or think is impossible. What led you to decide that that was the course you wanted to take?
Well, I mentioned earlier that we've tried to do this down partisan lines, and it's not worked. So if you think about the two issues that seem to kill healthcare policy is one, if CBO scores something and says it's going to cover fewer people, it's kind of the death knell for it. That was one of the big problems with the AHCA. Whether CBO is right or not, if that's the way the score comes out, it makes it tough to get policy moved forward. We know the rising cost of healthcare. If CBO puts a score out that says healthcare policy is going to increase the cost of healthcare, that's pretty much a non-starter for a lot of people on Capitol Hill. So why can't we have better healthcare that covers more people, that covers pre-existing conditions, and lowers the cost? And I'm convinced, 100% convinced we can do that, because when you get into the details and you start looking at different systems and the way they're put in place, the way they're being taken advantage of, if we can make healthcare fair, we can also make healthcare lower cost and make it available to more people.
There are 5 titles to the bill. The first title is about private insurance reform and the tax policies related to health reform. The second is Medicare and Medicaid reforms. The third and fourth are hospitals and drugs. I always get them mixed up, which is Title III and which is Title IV. And Title V is digital health reform, trying to reform the way how patients own their medical data and how that can be deployed to improve their care.
Yeah, all kinds of innovation in healthcare.
One thing I'm struck by, there are 2 things I'm struck by in terms of the overall policy thrust of the Fair Care Act. The first is as you mentioned up on the podium, your big belief is that the right way to reform healthcare is for more Americans to shop for their own health insurance as opposed to getting it from the government or their employers. And the second thrust is, as again you noted up there, employers are generally failing to control the cost of healthcare. I know at FreeOp, our premiums went up 15% last year. And we are pretty smart about the way we pick healthcare benefits, just like you were at your engineering firm. 43% of Republican voters support or are open to a public option, a government-run insurance plan to compete with private insurers for their employer-based health insurance. So it seems that even among Republican voters, there's an increasing skepticism about the role of private insurers in the private market in delivering health insurance. And a big thrust of your plan seems to be to try to tackle those problems so that employer-based insurance and individual insurance work better. Tell us about why you came to that approach.
Yeah, well, number one, I think it's because I'm a free enterprise person, and I believe that the free markets are always a better approach than having a government-run system. I mean, think about Medicaid. Some plans are being called Medicare for all. I'd say they'd be much more aptly named Medicaid for all. Find anybody that thinks Medicaid's the best healthcare program out there. Providers don't like it. Studies have shown that the benefits to the beneficiaries are not, or the outcomes aren't as good for other health coverage programs. And then you've got the VA, which is another probably model of what a single-payer, big government-run program would be like. I know when I was doing engineering work, I was doing projects in the UK, and I remember visiting with folks there when they were talking about their national healthcare system, and they explained to me that being a visitor to the UK, if I had an emergency, I would go to the emergency room, I would be seen, probably get good care, and it wouldn't cost me anything, that they would pick up the tab for it. But they said if I was a resident of the UK and I thought I might have cancer or some serious disease, that it could literally be 6 to 8 months before I could get in to see anyone. I remember this gentleman telling me about his wife, who was an emergency room doctor, that gave up medicine because of the red tape involved in providing services. And then they talked about how they passed this national health care system to give everyone equal access and better care. And they said it did more to stratify health care in the UK than anything you could have ever imagined. That the ultra-wealthy built their own kind of country club hospitals and clinics. They went out and hired the disenfranchised doctors and medical workers to work in their clinics, and they had their own private health care system, while everybody else that couldn't afford that suffered on the government-run program. So I really think that, and especially in America, that the free market is the best way to go. You've got to get competition there, and competition not only helps with prices, but it also helps with innovation. And we want to keep American healthcare in the forefront as a leader in the world, and free markets are the way to do that.
One of the people on our team who's here in the audience, Kara Jones, has a lot of experience working with employers who offer health benefits, and she has pointed out to me that a lot of employers, and not just voters, there are voters who are skeptical of employer-based insurance and how their deductibles have tripled and how their premiums keep going up and their wages are staying stagnant. But employers are also starting to feel like they're throwing up their hands and saying, we can't control healthcare costs, we want to get out of this business. I mean, what are you hearing from employers? And you talked about Walmart, but how about the smaller businesses, the 50 to 100 employee companies? What are they saying about healthcare?
So, I haven't been a part of a small business since 2014 when I got elected, but I know that for a decade or more, it was a major concern with our company every year. How much can we spend on health care? How much of the burden are we going to have to shift to the employees? And every year we were having to spend more as a company, plus shift more of the burden to the employees, plus reduce the amount of benefits that the employees were getting. So it's a frustration. It's really not something you have a lot of power to deal with. You kind of take what's offered to you. You get bids on your health insurance providers, and you take the best one out there, and you go on and hope for something better the next year. If we can create a larger individual market and get more competition on the individual market, if we can do more to address the real issue with increasing healthcare costs, and that's increasing prices, then I think we can not only help people who are getting insurance on the individual market, but also help those who are getting insurance through their group plans.
Let's talk about the politics now. So obviously, health reform is always hard. It's always hard to get conservatives and progressive Democrats and Republicans to agree. It's hard to get voters to agree. It's hard to get lobbyists to agree. There are all sorts of people who have a stake in the system one way or another. How have you found it navigating all that? And when you started on this endeavor 2 years ago now, and you said you wanted to put together a bipartisan health reform bill, has it been harder than you thought, or about as difficult as you expected, or easier than you thought?
I would say, easier than I've thought to go out and gather the information and compile it and to analyze the data and figure out what should be in the bill and what shouldn't be in the bill. And it's also created a basis where I can go talk to Democrats, I can talk to Republicans, and make valid arguments on individual policies. So I think that's how our country was set up and how it should be. But I mean, unless you've got a 60-vote block in the Senate, you're just not going to get health care policy on the floor of the Senate unless you do it through budget reconciliation. And what I found out being on the budget committee and wading through the AHCA is you're limited on what you can do from a policy standpoint when you're trying to do it through budget reconciliation. You know, the fix to the ACA had to be done through reconciliation. It was pushed through in December. Senator lost, Democratic senator lost, Republican senator won, so they didn't have the 60-vote threshold, and they had to come back and try to fix it through reconciliation, and I don't think it's ever been fixed. But I think we can take the good ideas, get bipartisan support, and if we want the best for health care in our country, that's the approach that we have to take.
Do you find when you talk to voters back in your district that people are excited about the opportunity to have more choices in their health insurance, or is their attitude more, just get the cost out, I don't care if I have choice or not? Or is it both?
I think people want the choices. They want value for what they're paying for. And that's why we call it the Fair Care Act. You pay for a service and you're going to get the fair services back that you've paid for. We want consumers to feel like they're getting a good value for what they're paying for. Right now, people are just paying enormous amounts of their disposable income for health care. I know, personally, I'm now a participant on in the individual marketplace as a member of Congress. And, instead of a group plan like I had previously, I have to analyze individual plans for my whole family. And when my kids went to college, we found it was always less expensive to buy whatever plan the university had for students and not participate on the exchange with the whole family. But it doesn't have to be that way. If the exchanges are a good idea, they just have to have more people participating on them and more options on the exchanges.
Maybe we can go back to the policy since you brought that up and talk about some of the key elements of the plan. So one element, Title I, a lot of Title I is about repairing the individual market so it works both for people with pre-existing conditions and healthy people whose premiums have raised up. You mentioned on the podium the idea of reinsurance or a high-risk pool to directly cover the costs of sicker people so that premiums go down for healthy people and more people can enroll, widening the age bands and some of these other reforms to make the individual market stronger. One thing that plays into that is the reforms on the employer-based side. So you mentioned about how in Congress you now shop for coverage on the Affordable Care Act's exchanges. One provision in the Fair Care Act is to transfer all federal employees onto the exchanges, where they would use health reimbursement accounts funded by the government to shop for individual market coverage. You also have a related provision in the bill that would take advantage of a new rule that's come out from the Trump administration to not only enable existing employers to optionally fund health reimbursement accounts or health reimbursement arrangements so people can buy coverage on their own, but starting in 2021, every new startup, every newly incorporated business, that would be the model going forward. So new businesses that were founded after 2021 would also would be required to fund, if they wanted to take advantage of the tax break for health insurance, fund health reimbursement accounts so the workers could control those dollars and shop for coverage. So a lot of really interesting and subtle but significant policy tweaks that over time will lead the individual market to be a lot larger than it is today. And one could see it actually tripling or quadrupling or even more in terms of the cumulative effect of all those reforms. Tell me about that thinking. I mean, you're really making a bet that that the individual market can be a lot better than it is today, and that it can serve a lot more people than it does today.
Well, we see from private insurance that the larger the group, generally the more value you get in your plans. And that's why you see large employers self-insured. They have enough employees, then they have a large enough group, they have good bargaining power, good buying power, and they're able to negotiate better. And you can almost think of the individual marketplace as a massive group plan. And the more people you can get into that plan, and the more insurance providers you get offering plans on the exchange, then you're going to have more competition and more options. And I think it's just a great approach to lowering the cost for individual consumers. And that's the main thinking behind increasing the size of that pool. You mentioned the Federal Employee Health Benefit Plan. That's, I believe, around 10 million people, give or take, that would automatically make that plan larger. If you look at the people who are now covered under the Affordable Care Act who weren't covered before, most of that took place under the Medicaid expansion. We would also like to get away from fee-for-service Medicaid and the Medicaid expansion and take that population and use a premium assistance program to help them get onto the exchanges as well. And then finally, the option to for new businesses that start up after 2020, 2021, they would be able to participate in the individual marketplace as well. So the idea is to grow the individual marketplace and make it what that marketplace was originally intended to do.
I'm going to ask one more question, and maybe we'll open it up to a question from the audience. Since we're here at AEI, we should mention that one of the ideas you're considering, as you mentioned at the podium, for the new version of the Fair Care Act is to incorporate a version of competitive bidding into Medicare and Medicare Advantage. We talk about the individual market a lot. We forget that Medicare Advantage is the largest and most robust individual market in the United States. Tens of millions of Americans are enrolled in Medicare Advantage and shop for coverage every year through robust competition for private plans. And you're thinking about expanding the role of competition in the Medicare program to bring those costs down for seniors and for taxpayers. Maybe mention that a little bit.
Yeah, and
I should mention Jim Capretta is the guy who is the really originator of a lot of this work.
Yeah, and I think that's a great idea on how you get competition there, so that the federal government seems to want to get assurances on capping cost, and that's kind of how they've set up that program on Medicare Advantage, where you get to share in savings. Well, we want the taxpayer to share in those savings and not just have a set cap. It kind of goes back to the conversation I had with the independent pharmacist on the DIR fees. Like there's an average amount that the federal government expects to pay for a prescription. Part of that goes to the pharmaceutical company or the pharmacist. Part of it goes to the PBM, and the government gets to save money, but all the cost savings being squeezed out of the individual pharmacist. We want to be able to competitively bid and let the markets work so that we can get the cost even lower for Medicare Advantage plans.
Right. All right, questions for the Congressman? Yes, ma'am. There's a mic coming. And please introduce yourself.
Thank you. Hi, I'm Sarah Hansard with Bloomberg Law. Congressman Westerman, can you comment on the role of Medicare prices? I've been doing a good bit of reporting on how employers pay so much, 2-3 times more than Medicare price, and then doctors and hospitals keep saying, well, the Medicare price is too low, that's why we have to charge employers more. Do you have any thoughts on that? I mean, somebody sets, and I've talked to Ovik Roy about this, somebody sets those Medicare prices. Do you think that they're really set too low, or should we use Medicare as a benchmark for what employers should be paying?
Well, that's the world we're in right now, and I learned this through just a lot of research and talking to people back when I was in the state legislature, that Medicare prices set the price for everything. Insurance reimbursements are pegged off of Medicare reimbursement rates. Medicaid reimbursement rates are pegged off of Medicare reimbursement rates. And when you get into the details of that, especially talk to surgeons and other physicians, and they talk about how the system is so messed up. Like I remember a neurosurgeon was telling me about a certain back surgery where there were 5 or 6 things that needed to be done to make the surgery successful, but Medicare only paid for 2 or 3 of those things, and he can't do a halfway back surgery, but he can only get paid for half of a back surgery. We've got to get healthcare providers, and I'm talking about doctors, more involved in setting those, not necessarily setting the process, but outlining how those payments should be. Whether we stick with Medicare continuing to control that, we don't necessarily address that in the bill, but I agree with you that it's probably not the best way to do it. So if anybody's got a better idea on how we attack that from a pricing standpoint, I'd be open to hear it. But it just gives everybody a reference point to work from, and they're always working from how much Medicare will reimburse for certain procedures. And maybe that's an area we need to look at in the bill that could have a good impact. Do you have ideas on that? It sounds like you've researched it.
Some providers will pay you what Medicare pays. And I go round and round it because you talk to different people, including Mr. Roy, I believe, different people have different ideas about whether Medicare really is underpaying, or, have providers, or at least hospitals, shifted costs to, into their system that then becomes a higher cost basis, or...
And what I've found is it depends. You'll find some things where they really underpay and some things where they overpay. And you've seen a move towards these clinics that don't accept Medicare, they don't accept Medicaid, they don't accept insurance, and they're able to price medical services based on what the cost for those medical services are. I know an individual who shifted his company to a plan that basically took advantage of these concierge services. He tore a rotator cuff, and he called around. He was in Little Rock, called around, and I think the price was somewhere between $25,000 and $30,000 to have the surgery in Little Rock. But there's a surgical center in Oklahoma City that they would pay for his transportation out there and the surgery, and the price was more in the $5,000 to $6,000 range. So they were charging what the true cost was to perform the procedure, not what Medicare said was the rate, and what the hospitals tag on to make sure that when they're through negotiating, they're going to make a profit off of the service. So somehow, if we can get back to more transparency in pricing, where the consumer is actually paying for the cost of what goes into the procedure, I think we would be better off.
Well, Congressman, I just want to thank you for being here and for the impressive work on this proposal, this bill, which I think any healthcare expert who studies it is going to be very impressed by how serious it is at addressing a lot of the problems that we all agree we need to tackle. So thank you very much.
Thank you, Ovic.
And I know the Congressman will be around.
Yep.
For the rest of it, I'll give the mic back to Jim. Okay.
By the way, nobody's allowed to take the chances with that gap. Am I on? Yeah, okay. While the panel's getting seated, let me introduce myself. I'm Joe Antos with the American Enterprise Institute. One of the many points that the Congressman made, I thought really struck home, especially in the context of the coming election debates and the ongoing debates among Democrats right now about health care. The Congressman pointed out that what I think is what Americans are really concerned about. What are they concerned about? He made reference to his child, I guess that was 20 years ago or something like that. And so what was the first thing on his mind? It was access to the appropriate care. What was the second thing on his mind? Could he afford it? Those are the big issues. And then what was the third issue that he raised? As an employer, it was how is the employer going to be able to cover the cost? And implicitly, how are the workers going to be able to cover the cost of insurance? In other words, it's not about the issues that the Congressman raised, I think have been the issues all along. They remain the issues for most of the voters in this country, which is, the fact is that most of the voters in this country are covered by insurance. And so the issues for most of the voters in this country have to do with access to care and cost in some form or other. Might be through an employer, might be personally. But one way or the other, those appear to be, to me, the big issues. And yet, what we have is, to me, a little cognitive dissonance, it seems to me. Because we have, Democrats seem to be fighting the last war over coverage. And they're beating themselves up. I mean, it's kind of gratifying in a sense because this is kind of what Republicans did, years ago, 4 years ago, 3 years ago. They beat each other up. And in the end, the issues were not resolved among Republicans. And they, I think, are largely remain. There's still issues that remain to be resolved among Republicans if Republicans come back in power in the Congress. And by the same token, Democrats are picking up issues that I thought were largely resolved about coverage and saying, no, that's not good enough. So it's I find that quite interesting and should make for an interesting and complicated year and a quarter or so before we get to the election. Let me introduce the panel. Let me find my notes. And I'm going to introduce people in the order in which they'll make initial presentations. Oh, my goodness, what did I do? Oh, there it is. Okay, first of all, we have, sorry about that. First of all, we have Karen Pollitz, who is Senior Fellow with the Kaiser Family Foundation. And I'm going to mention a little something. Normally, I just say, name and rank and move on. But in this case, it's kind of interesting to know something, a little bit about their background and their relevance to today's political issues. So in particular, Karen was at HHS working on national health reform during both the Clinton and Obama administrations. So that's, but beyond that, she spends an awful lot of time with her colleagues trying to figure out what is everybody saying, and that's going to be how we're going to start off this conversation. The next person speaking is Kavita Patel. She's a physician and a non-resident fellow at the Brookings Institution, and she was deeply involved with the Affordable Care Act. She worked for Senator Kennedy, was a senior staff member of the Senate Help Committee, working on health reform, and eventually ended up in the White House under President Obama, again, working on these same issues. Third person, Jim Capretta. Jim sort of introduced himself. He's a resident fellow at AEI, but in addition, he spent a few years at the Office of Management and Budget in the George W. Bush administration, working on a lot of issues, but in particular, healthcare issues, Medicare and Medicaid, and financing. And then Lan Hee Chen, who is a research fellow at the Hoover Institute or institution rather, and director of domestic policy studies at Stanford University. His particular part of his background that makes him extremely relevant is that he was the policy director for the Romney-Ryan campaign in 2012. So he has, I think everyone on this panel has some political scars to show, and ideally they won't show them very graphically, they will be polite about it. I'm squeamish myself. And then we also invited Ovik to join us because there will probably be a little back and forth about the Westerman plan too. So with that, Karen, maybe you could start now. Let's see. How do we
Want me
make the
to
slides?
stay
move?
here or go there?
You can do
Do you
either way,
have a
whatever you're more
clicker?
comfortable with.
Yeah, whatever you want to
I'll stay here.
And you have a clicker?
Yes, then I won't fall in that
Wonderful.
gap. Yes.
Exactly.
All right. So, let's see.
Here, bring up your slides. Yeah.
Slides are coming. we
So
think.
while we're putting up the cover, Joe and Jim asked me to talk about the work that we've undertaken at Kaiser Family Foundation. During the repeal replace debate, thank you very much. We tracked all of the proposals, the Republican proposals, put them together in an interactive side-by-side. Since that debate closed, we've now started tracking the Democratic proposals in the Congress on the Senate and the House side to build on or replace, as the case may be, the ACA. My remarks today are sort of build on that, are based on that. You can go to our interactive on kff.org to see a detailed comparison of the Democratic plans. Since we put that up, a number of the Democratic presidential candidates have begun to introduce their own proposals, some with more or less detail. So I'll do my best today to try to situate those into this discussion as well. My remarks today are based on our analysis. Kaiser Family Foundation does not endorse any party or candidate or proposal. So these are some of the things we've been looking at. There are a lot of proposals that have been introduced on the Democratic side, many invoking the name of Medicare, and many of them building on the Affordable Care Act by introducing a public plan option, a new public plan option. Even though the names look similar in many respects, these proposals do vary in significant ways, and I wanted to just kind of look at 6 kind of top-line issue areas on which they do vary, and then turn it over to my colleagues. So the first dimension on which these proposals vary has to do with how big the public plan is, what is the role of the public plan, and how much would private insurance continue under these various proposals. And there's really a range. On the one side, you've got Bernie Sanders' Medicare for All, which would create a single-payer system called Medicare, Medicare-ish, different from the current Medicare, that would cover everybody, and there wouldn't be any more private health insurance. At the other end, there's a bill introduced in the last Congress and in this Congress by Senator Warren, who, by the way, is also a co-sponsor of Senator Sanders' bill, that would build on the ACA without creating a new public plan. So it would enhance subsidies and add additional kind of standards and protections, but no new public plan. And then in between, most of the proposals would establish a new public plan, but those vary as well in terms of how big it is and how much private insurance would continue. I've put some of them in a category that I just personally call Medicare for most. So most people would be in the public plan, but there would be an option for people to enroll instead in a Medicare Advantage plan or to opt out into their employer's plan if that is still offered. And then most of them would offer the public plan on the marketplace. In some, people other than marketplace enrollees would be able to participate in that, employees, large employers. Most of them, this public plan would only be an option for people who are in the marketplace. So actually, most of us would never get a crack at that. And then we've got these Medicare buy-in proposals where the public plan would only be available to marketplace participants who are over 50. Now, I just wanted a little background from our public opinion polling. We have found for the last couple of years that there is a majority support for the concept of Medicare for all, a slight majority. It is largely partisan based, but when you ask people about a public option, whether it's a Medicaid buy-in, a Medicare buy-in, a public option on the exchange, public support grows, and it's much less partisan, as was mentioned before. There's a lot of independent and Republican support for that as well. So option really seems to be a magic word. People, I think, are interested in that. We probe the Medicare for All supporters. What we find is that actually people don't know that much about what's in these plans. They get confused. A majority of people who say they support Medicare for All believe they would be able to keep their current insurance. So there you go. And when you give various arguments, that really sways what people think about Medicare for All. And one in particular that's gotten a lot of attention is the argument that if Medicare for All would eliminate private insurance, what do you think about that? And then a majority does not support Medicare for All. Now, I don't believe that that is an indication of how devoted people are to private insurance companies, but rather a concern for having to give up coverage that they have for a new program that they don't really know what that is. So, okay, back to how these proposals vary. Another key issue has to do with how much coverage would be subsidized under these proposals. We've talked about there remain a lot, still millions of uninsured Americans, and the main reason why they're uninsured is they can't afford to sign up for coverage that is available to them. So again, we see a range. The Medicare for All plans, both Sanders and Harris, would not have premiums, so the monthly cost of enrolling would be completely subsidized by the taxpayers. On the other end, there are some bills that would create a new public program but not change the current law ACA subsidies at all, who's eligible for them or how much they're eligible for. And then in between, most of the proposals would not only establish a public plan, but they would enhance the current law ACA subsidies, so extending them to more people or expanding the level of subsidy. These proposals also vary on how they would affect cost sharing. We've talked a lot today about rising deductibles and how much people have to pay at the pump when they do get sick, and this is a huge concern. And again, we see a range. In the Sanders Medicare for All, there wouldn't be any cost sharing. Everything would be covered under the public plan, 100%, no deductibles. At the other end, we have some, again, proposals that would establish a new public program but not sort of change the current law cost-sharing rules or subsidies. And then in between, most of the proposals would expand cost-sharing subsidies or tighten standards for how much cost-sharing could be applied under remaining private plans. Some would do that broadly for people outside of the marketplace as well as in the marketplace. And then many of the proposals would expand the cost-sharing subsidies in the marketplace today, tying them to a gold level plan and making more people eligible based on income. And I include this in my list because our polling shows when you just ask people up front, what are you worried about? They really are worried about what it costs to get health care, and we've talked about that. The Congressman talked about the rising deductibles for his small businesses and so forth. Our recent poll of people covered by employer-sponsored insurance finds that half of people in job-based coverage today tell us that they have skipped or delayed care because of the out-of-pocket costs. Deductibles have risen 8 times the rate of wages over the last 10 years, and this affordability is the issue that people tell us in our polling they are the most concerned about. So it's interesting how these proposals would address that. And then just these next two slides sort of address how these various proposals would affect our current public plans, the largest ones being Medicare and Medicaid. Medicare is actually the second largest plan, but I'm going to start with that since all of these invoke the name of Medicare. So some of them, the Medicare for All proposals and the Medicare for America proposal, would actually replace the current Medicare program with a new Medicare program that has vastly enhanced benefits. It would include dental and vision and long-term care, reduced or eliminated premiums and cost sharings. We have some of the public plan proposals, most of the public plan proposals really leave the current Medicare program alone. They sort of wall it off, and that's where you go when you're 65, and they wouldn't change the program. Two others, though, would make some changes to the current Medicare program. It would remain separate from the new Medicare public plan for younger people, but two of these proposals would add an out-of-pocket limit on Medicare cost sharing, which traditional Medicare has never had. But most of the public plan proposals do not change the current Medicare program at all, and don't change or wouldn't let people who are eligible for the current Medicare program to come into the new Medicare named public plan. And then with respect to Medicaid, which is our largest public program, covering over 72 million low-income Americans, these proposals also vary in terms of how they would change that. Some of the proposals would replace Medicaid and incorporate it into this new Medicare, Medicare for All plan. Two of the proposals, my apologies, a mistake, the Schatz Medicaid buy-in and the Biden plan would make some changes to Medicaid in terms of, you know, who can sign up for Medicaid and who can sign up for the new public plan. And then most of the proposals, again, leave the current Medicaid program as it is and don't change it. And then finally, this key issue about healthcare spending, which Ovik and the Congressman talked about. The U.S. now spends more than $3.5 trillion annually on healthcare, and the price per unit of healthcare in the United States is higher than in any other nation. And commercial insurers do pay considerably higher rates for healthcare than compared to the Medicare program. One of the goals motivating these public plan advocates is to increase coverage through government programs that have the authority to set or negotiate rates, different from the way that private insurers do today. However, while many of these proposals invoke the name of Medicare, most of them don't specify that current Medicare rates is what the new public plan would pay. Only a few specify that. Some of them specify that actually the public plan would pay higher than Medicare rates for hospitals, for providers in rural and underserved areas, for primary care, for behavioral health providers. And then 5 of the proposals, including the Sanders Medicare for All proposal, don't specify. They say the public plan will establish rates or will negotiate rates or they'll be based on current Medicare rates, but they don't actually pick a number, which is kind of interesting. So it seems like this is the sponsor sort of nodding in the direction that government should do more in this, but not exactly saying yet, maybe leaving the debate open about how much more they should do or how that should work out. Just to summarize, this kind of discussion about looking for common ground is I think a really important one. I think it's fair to say, given what I've shown, that on the Democratic side, there is not yet a position. There's a lot of differences in sort of how to proceed. And I think on the Republican side as well, with the Congressman's plan, with the actions taken by the Trump administration, with the repeal lawsuit and others, there's not yet sort of a coalescing of positions on the Republican side. Based on what's out there, though, there do seem to be some different directions that are being pursued. It'll be interesting to see if they come together. On the Democratic side, I think there is an interest in expanding on the ACA, the subsidies, the people covered through that. Different from the kind of continued efforts among some on the Republican side to repeal and roll back the ACA. The Democrats do seem very interested in expanding the role of public programs. On the other side, where there's still a lot of talk about block granting or limiting the Medicaid entitlement, limiting excuse me, limiting eligibility for Medicare, the Congressman talked about. There's an interest in making plans cheaper for people, more affordable for people through subsidies on the Democratic side, versus on the Republican side, making less expensive plans available that cover less, that have, copper plan level deductibles, or in the case of the president's proposal, short-term plans, which are much cheaper because they cover fewer benefits and exclude pre-existing conditions. And then finally, I think interest on the Democratic side in expanded government authority to set or negotiate prices. Less so, I think, on the Republican side, although there were a few interesting kind of PBM details, pricing rules in the Congressman's bill. But at this point, maybe more interest in price transparency. So I will stop there and turn it over to the panel. There you go.
Great. Thank you. So I'll just give a couple of kind of grounding remarks, and then I wanted to also just offer a little bit of a glimpse. I think all 5 of us have kind of briefed presidents, presidential candidates, and so I just want to offer a little bit of what's happening kind of at this moment, and as we're going into a debate Thursday night where many of the top contenders will finally be on one stage, kind of how in the backdrop of campaigns, and this is not meant to be an endorsement, but rather just more of a little lifting of the veil, because I think there's a lot of talk about what is going on inside of campaigns, and then there's the reality of what a candidate at this stage is trying to do, which is, I think, reflected in Karen's thoughtful analysis of why you don't see a lot of the details that we're asking for. But as time evolves, people are going to have to produce those details. So just first, a couple of grounding reminders. If we could kind of rewind a little bit later, but kind of still earlier on in the presidential Democratic primaries for 2008, for the 2008 presidential election, we had a then Senator Barack Obama and a then Senator Hillary Clinton who ultimately kind of came down, and every debate between the two of them was a debate around whether we should have an individual mandate that was broad, which was Senator Clinton's position, and then Senator Obama's campaign, which settled on just having only a children's mandate. And the reason I point that out is because obviously the Affordable Care Act had an individual mandate, and what you see in terms of where Democratic candidates differ, for example, even today with these kind of nuances around Medicare for all, or premiums and cost sharing, all those ideas eventually roll up. If there is, in fact, a Democrat in the White House in 2020, then all bets are off. It's not what they really campaigned on. It really does kind of roll up into, here are the various ideas that are good or bad, and then here's how we put it together. And that also reflects the fact that advisors to these individual campaigns, of which there are numerous and multiple and many Excel spreadsheets, all then kind of coalesce around the individual who becomes the nominee. Second kind of data point, just to recall for those of you that did kind of suffer through the Affordable Care Act debate seasons, there was a public option in the House version, just like there were some other important provisions that also went by the wayside in the ability to kind of negotiate a deal between the House and the Senate. The public option is one of the most notable ones. There was also a pretty significant amount of graduate medical education language in the House version that didn't make it into the final. A number of things, and then a third set of kind of important provisions around malpractice reforms that actually the White House had that ultimately didn't make it into the final. And there's been books written about a lot of this, but I think that it's worth refreshing because Nancy Pelosi, who was the speaker then and is the speaker now, certainly has not forgotten. So these are, I think, important milestones. The third is, I would call it, I just want to remind people, and this is something I had to personally live through, was the summer of 2008, summer of 2009 rather, before the passage of the Affordable Care Act in March of 2010, when we had protests and kind of town halls across the country with picket signs that said, "Keep the government out of my Medicare." And we had to kind of sit down internally at the White House, led by a team of people Nancy Ann DeParle, who was really leading the president's health reform effort, David Axelrod, who was his senior advisor on kind of all things communication, and really sit down and process what has happened. And what we realized was that healthcare is very, as President Trump likes to say, it's complicated. And we learned that the hard way, that kind of talking to people about expanding Medicaid and thinking about subsidies just does not translate. I think much to kind of what Joe was saying, like at the end of the day, if you're sick, you really want to make sure you have everything available to you, access, and then maybe second, I would offer that for a lot of the patients I see, they can't even deal with the cost as like the second, third, or fourth issue, but they just know that they can't afford it, and then they kind of block it. And I think that's actually where a lot of society is today. So we learned in 2009 that we had to start getting much more kind of granular on a grassroots level. And you heard the president say things like, if you like the doctor you have, you can keep him or her. And we knew that those of us that are serious policy wonks, just like when we're talking about provider reimbursement, we understand the myriad of perverse things that lead to why Medicare pays a certain rate. And it's not just because the government decides to pick a number out of the hat. And so we understand that, but we have a job to translate that. And I would say that the White House had to really learn how to pivot, and in that fall, work very closely with Congress. I think the presence of all of us talking about ways to improve health reform is actually a success of the Affordable Care Act. We're actually talking about doing something, whether it's replacing it, which we can talk about in the Q&A, but I also think that the fact that we're here talking about how we've done something at a massive level in this country for health reform, to me is a significant step forward. Was it perfect? No, but it's produced the fact that most of the Democratic candidates are now actually challenged with thinking about how to improve or what they could do, which is why I think healthcare will always remain a top topic. And then let me shift gears to kind of, I think all of us, again, can offer kind of a little bit of behind the scenes. I can tell you right now with pretty solid clarity, because I've worked with either the people that have put those plans together or been asked to react to them or have been helping with some of them kind of pen to paper. Almost all the candidates, with the exception of probably Senator Sanders, who really has just been using the legislation he has introduced as a basis for most of his comments, I think all the candidates are trying to demonstrate that they can appeal to the American public by offering something unique of their own, stamp, signature, name, brand, on health care. But obviously, they're also trying to deal with every other domestic foreign policy topic that there is. So even though healthcare is kind of probably everybody in this room's number one thoughts, when you wake up and go to bed, you keep in mind that they're kind of balancing a panoply of issues and also balancing their day jobs. So the job of getting what you see on paper, while every candidate does review and have input and ultimately have to sign off on it, is really coming down to a tenuous balance between paid campaign staff who are full-time and paid, and then this kind of universe of loose advisors, people like myself and others, Lanhi's done this, Afak's done this, where we are giving advice, but not necessarily kind of the owners of what the end product is. And I think what you see is very careful, and then the other part that nobody really speaks of, but I can say at least on the Democratic side has been present, is this kind of overlay of strategy and comms. That, at this point in time, everything is about messaging, getting kind of those Twitter, getting the tweets and those moments on Instagram, and getting sound bites that position their candidate to say that they're doing something. And that's why you see plans being rolled out time-wise before critical milestones, debates. There's just a very kind of almost predictable pattern to it. Nobody thinks that they're turning what you see on Karen's slides, which you can all find on the Democratic candidates' websites. Nobody thinks that you're turning that into ledge council language, because there's not enough there. And I think everybody acknowledges that. Again, I would say with the exception of Senator Sanders, who has legislation, and I think he's pretty clearly said, I think he said I drafted the damn bill. So I'm pretty sure he's the only one that can kind of point to details in hand, but even then there's not some details that a lot of us would like to see. So having said that, what can we expect? And some of us were talking about this beforehand. Until the field whittles down, which will happen just by the fact that as time goes on, the caucuses and then fundraising cycles, and we'll just see fewer and fewer candidates. Until then, we're only going to see these, I think, very general talking points, these general plans that offer the name, but not much more than that. And then as things whittle down, then you'll start to see more details, and you'll also start to see more surrogates that emerge. And I was a surrogate for the Obama campaign early on, and so people will start to kind of be identified with one particular candidate, and then that person will end up having the fortunate or unfortunate job of kind of filling in some of the blanks and hoping that they don't screw it up, because then the campaign is watching and will absolutely kind of, make sure that those people no longer speak if they're not representing the candidate in a positive light. So when does that all kind of shift to like the real policy wonk, material details? Honestly, it's probably a little bit before the actual election, but not that distant from the election. And then there's this hurry up period in the transition where people are trying to fill those roles. So I paint that just because I think it's going to be months before we see the kind of details that we're asking today. However, it's a great opportunity. Just my one kind of, for the people watching and in the audience, thinking about how they can have an impact. Lots of campaigns are getting phone calls from very interested people who have very important names and titles who say, I want to help. Probably the best way to actually have an impact is to do some of what I think all of us have tried to do, where we publish or at least have a presence in kind of a high impact. Everybody talks about the Wall Street Journal op-ed or the New York Times op-ed. That's nice if you can get it. But in this day of evergreening material on the internet, it really just takes having something that really helps to dive into an issue. And it's not that the candidate is going to see it, but you can guarantee that somebody in the social media universe will get that into the right hands. And I would say that's probably between now and January, February, a way to have a significant impact on some of the gaps we see. So I'll stop there, Joe, and we can talk about more later if appropriate.
Okay, thanks.
Okay, thank you. I think I'll pivot a little bit and talk about how I see the Republican side of this shaping up a little bit, and then come back and talk a little bit about some of the things that are happening on the Democratic side. So I think the big question mark really is, we've heard a lot about what the Democratic candidates are thinking about, the Congress, a lot of activity and so on. What is the Trump administration's plan? And I think it remains something of a mystery, which we might hear a little bit more about in the coming weeks. Recently, there's been some reporting in the news that over the summer, the administration was signaling, as the Congressman mentioned, earlier this year, the president said something to the effect of, we want to be the healthcare party or something to that effect, which was greeted with a lot of groans amongst Republicans in Congress who do not relish getting back into another healthcare debate. But the president sort of said he wanted to get out in front of this and have something proactive. And then over the summer, there was some reporting that they're having meetings and talking about it, and they had a meeting in Camp David amongst the senior level staff in the administration. What are they going to propose? Potentially as a counterpoint maybe to Medicare for all or some variation of the public option, which seems to be likely as a proposal from the Democratic candidate. And then there was a signal that maybe the president was going to give a speech about it quite soon, like in the next month or so. But as all things with the Trump administration, it's a little bit sort of like, who knows, right? So plans one day vanish and no one ever hears of them again, right? So it's not at all clear that they will have a plan, or if they do, if the president will give a speech about it, or if it'll evolve to something. So I think it's just, TBD right across the board with the Trump administration. I think their choices, though, are basically one of two things. They could either try to have a thematic plan that they put out that in some ways mirrors the Democratic side, some specificity but not to the granular detail, put it out as a campaign kind of document, have Alex Azar and others speak about it and push it, and this is their actual plan as they would propose it. Or they could rest on sort of what they've already done and have that as an offering to the public about what they would do in healthcare and build upon the record that they have, which I know is a lot of people will think it's pretty thin, but actually some of it is fairly consequential, and mainly attack the Democratic plans, which probably is the safer position if you're the candidate at this point. More about that in a moment when I talk a little bit about the Democratic plans. So I think those are the two options for the Trump administration. Try to actually roll out some thematic plan that serves as a counterpoint to the Democratic ideas, or rest on what you've already done and mainly be in attack mode against the other side's ideas. And if they pursue the second option, what is in their record that they would actually run on? Well, as has been mentioned, they have done a fairly large number of things through administrative action, some of which are negative, some of which are positive from my perspective, but they have a fairly long record, and they can run on that to some degree. So they did propose short-term duration plans, and they put it in regulatory language. It's now in effect. Those plans are being sold, and actually a fairly large number of Americans are signing up with them. Now, for whatever one makes of this idea, it has, in a sense, made available to people in the individual market some very low premium plans for people that are basically healthy. As Karen has mentioned, these plans do not have pre-existing condition protections. So that means if you're sick, you basically can't get them. Okay? You're going to have to go into the exchanges where there's protections. But for people that are relatively healthy, they'd be it's essentially a way to get out from underneath the ACA's regulated high premium plans and buy a low-cost option. Now, for better or worse, CBO has said that this plan in isolation, by the way, actually will increase enrollment in health insurance in the United States. Okay, so one thing to keep in mind, if you took just this thing away, forget about everything else, just this one policy, and X'd it out and said, we don't want to do that anymore, the number of people with health insurance in the United States would go down, not up. Okay, because there are a lot of people who would just forego going and getting insurance altogether because it's too expensive to go into the exchanges relative to their health status. So given that, this is something that I think probably the Trump administration will probably run on. The second thing they'll probably run on are health reimbursement arrangements. That is something the Congressman has talked about, which is trying to make it easier for people to buy into the individual insurance market through their tax-preferred contributions from their employers. This is something that the actuaries at HHS believe is going to have several million people will take up this option over the next decade. And so this is not a small matter. It's going to be, at the end of the day, probably as big as the size of the exchanges in terms of the number of Americans that are in it. So, think of all the hullabaloo around the Affordable Care Act, setting up the exchanges and everything else. This one policy is probably going to affect as many people as are in the exchanges today. So this is another fairly consequential policy that they've rolled out. They are also trying to work with the states around Section 1332 plans. So in a number of states, they've allowed these reinsurance plans to go forward, and they've substantially lowered premiums in a number of states as a result. And they have been fairly proactive about allowing any state that wants to do it, which, frankly, I'm not sure why every state doesn't do it, because most states would end up with lower premiums in their individual insurance market. So I think you're going to see high take-up of that option in the next few years as more states kind of get around to figuring out how to do it. And then finally, I just mentioned, obviously, a big issue when you look at the polling and people's concerns and the anecdotes you hear. Obviously, prescription drug pricing is the thing that people end up seeing more clearly than they do oftentimes physician or hospital payments because they go to the pharmacy, or it's somehow the price that is affecting the prescriptions is more visible very often to a consumer. So the Trump administration's been more aggressive on this front than any administration, including the Obama administration, and on record. And so I think there's going to be a lot of noise around who should get credit around prescription drug being aggressive to try to get something done on prescription drug pricing. That may result in a bill getting enacted this fall or not. It's a little bit hard to tell. But I do think there's almost no question that this administration will try to run to be the much more aggressive about this than even the Democrats they end up running against, where there's been a lot of talk, but not a lot of action. And so I'd say there they may actually have an opportunity to have a political leg up. Now, one thing I want to get to, though, regarding this idea of maybe running on the record they have and being more just aggressively against what they're running against, is that I do think, as we heard it from the discussion here, that there's a couple things about the Democratic side that, and I'm not probably in the best position to speak to the Democrats about what they should or should not be doing, but they're a little bit curious to me. I'm a little bit perplexed by it a little bit. Something that Joe alluded to at the beginning, which is they just went through this gigantic, agonizing 3-year effort to get the Affordable Care Act passed a decade ago, which was a monumental effort. Ask President Obama, okay? And it was supposed to be the plan that led to universal coverage for the United States. And it's almost as if the Democratic primary today is saying that didn't work, or it wasn't sufficient, or something to the effect of that agonizing, nearly, killed us debate from 10 years ago. Oh, never mind. We still need to pass some big, gigantic thing to get universal coverage in the United States. And then you have to scratch your head and say, is that really true? What's going on here? And when you dig into the numbers a little bit, when you go and you hear the Democrats talk in these debates, they almost always say, we need a universal coverage plan. And then when you dig into the numbers, you say, well, wait a second, what was the Affordable Care Act supposed to do? And when you look at the actual uninsured numbers, remember, there are about 30-some million, maybe 32 now or something like that. The vast, 2/3 of them are already eligible for something heavily subsidized by the federal government through their Medicaid program or through the exchanges, or they have an employer-sponsored option. So then you ask, well, what are they going to do differently from that? Why aren't we just trying to make sure that people are getting into the plans they already have available? And then there's another group of people that aren't insured who the Affordable Care Act specifically excluded from the subsidy system. Those are people who are in the country without proper documentation. This was not something Republicans forced on the Democratic Party. They wrote it into their bill not to provide coverage to them. By the way, which is very consistent with international norms. Every country that runs nationalized systems says if you're coming to our country without proper documentation, we're not going to be able to give you our full health care plan. Now, oftentimes they will give some level of service, which we do in the United States as well, by the way, but they don't say you're eligible for the National Health Service in the UK if you're not there living there legally. And the same with Canada. And so then the question is, would they really be able to enact something that provided free health care to everybody in the United States, even for people who are coming to the country without proper documentation? It seems unlikely that that could be a position that would be sustainable. So I think they've opened themselves up by emphasizing universal coverage to some level of scrutiny that may not stand up over time. There are some people without coverage in the United States that are sympathetic. Those are people in the coverage gap. And a lot of them are sympathetic, but I'm saying that, or all of them are sympathetic, I should say, but there's a coverage gap in the United States where people don't have good options. And that's the non-expansion states below the poverty line. And there are about 3 million people in that group, but that's not 330 million people, okay? So we ought to be fixing that problem for sure. But I think the Democrats seem to be kind of gotten themselves wrapped around the axle about a problem that they were supposedly really addressing forcefully 10 years ago. And let me just say one other thing, and I'll turn it over to Lon He, which is on the public option, which is sort of the kind of being presented a little bit as the moderate version of, when you look at the polling data that Karen presented, it's obviously much more popular with the public. Say, we're not going to force anybody to anything, but would it be good if the government ran an option that people could get? And a lot of Americans will nod their head and say, yeah, that would be good. A little pressure back on the private insurers, a little more competition. It's an option in case my private insurance is lousy. Why not? Given all the dysfunction in American healthcare, this seems like it might be something that would solve some problems. So you can understand why people are for it. But there is a wrinkle to this that's very important, which is it's optional for the public, but the question is it optional for the doctors and the hospitals? Okay? And if you look at some of the plans, the key to making them work and big and robust is they say to the physicians, if you accept Medicare, this is the Bennett Medicare X plan and some of the others, if you accept Medicare, you have to accept the public option enrollees too. So they fold these folks into that mandate, okay? That's the way they can then contract and have a very large network of physicians taking care of the people in the public option. If they don't do that, you end up in a situation like Washington State, where they're going to throw a public option party and none of the physicians want to join it, okay? Because the rates are going to be too low, okay? So I think there's a real important question there, which is, can they make the sale to the physicians that, hey, this is going to be good for you and you have to go in it, I think at the end of the day, the physician community is going to be very opposed to mandatory participation in the public option, which is going to make this a much smaller deal than it maybe looks at first glance. Thanks.
A lot of my colleagues have touched on, I think, some basic points. Let me just say, I think Democrats and Republicans are in a very different position now when they think about how to approach this from a campaign setting. And what I would say is I think the Democrats are in a very dangerous place right now. And I say that because the challenge that they've seemed to have taken on themselves is this. How do you draw differentiation between people who essentially agree on 98% of things? Okay, every primary campaign features this challenge. The Republicans had it. We had it in 2012 when I was policy director for then Governor Romney, then former Governor Romney. You know, you're running in a primary where you basically agree with your colleagues about most stuff. So you're looking for areas of differentiation, and you end up with these sort of very minute distinctions, what are actually relatively minute policy distinctions that you try to blow up into something massive, but really they're not massive. And you end up looking kind of silly as you do it. And I think the Democrats saw that in this debate they had that was aired on CNN in Detroit a few weeks ago, where the moderators spent a good amount of time on healthcare. I think they spent maybe half an hour, 45 minutes on healthcare. And I can guarantee you that 95%, 98% of the American public watching had no clue what any of those distinctions meant or why it mattered. Yet for the candidates on stage, it was the most important thing to emphasize, well, my plan includes this element of reimbursement rates, and your plan, Senator Harris, doesn't. So what does that mean? Senator Harris, how do you respond? Well, let me tell you about the distinction I have in my plan, which nobody cares about, by the way. So the challenge in this stage of the campaign and in any primary campaign is how do you draw bright line distinctions on things about which there really probably shouldn't be those distinctions, because to Kavita's point, everyone's going to have to come online with the nominee. Everyone's going to have to fall in line with the nominee, whoever that is. And so the distinctions now quite simply don't matter. But I fear for the Democrats that a lot of people are telling these candidates, and I've been inside and outside. I was inside in 2004, 2008, and 2012, and I was outside in 2016. I fear that what's happening for a lot of these Democrats is that advisors on the outside are telling them, hey, you need more detail. Hey, you need more distinction. Hey, you need more differentiation. And that's the last thing you want, actually, right now. I tend to think that at this point in the campaign, providing that only gets you into trouble. And it gets you into trouble in the way that it's gotten Senator Harris into some trouble, in the way it's gotten Vice President Biden into some trouble, which is to say, you need to begin to explain a plan which really isn't fully baked yet. And you're trying to explain this plan, you're trying to fly the plane while it's not completely built, and you're seeing the damage that does. To Senator Harris's campaign, it's disqualified her, I'd argue, on the question of what does she actually want to do with respect to private health insurance. She has a plan, maybe, but that's not the way she's described it. For the vice president, he's been pushed farther and farther to the left, and I think it's going to make it very challenging for him to recover that position in the general election campaign. Okay, so shift over now to President Trump. You know, his campaign really doesn't have to do a whole lot of anything, to be honest with you, in my view. I think to Jim's point about do they actually need to come out with this dazzling new plan, the dazzling new plan is probably going to be a restatement of what they've done already. And if I were advising that campaign, I would say, fine. That's a perfectly reasonable place to be. Because the president's administration has taken a number of steps which are relatively consistent with where Republicans have always felt healthcare needed to go. Offer more optionality via short-term limited duration plans, health reimbursement arrangements, making them more robust, trying to figure out a way to expand the federalist framework in healthcare. Jim referred to Section 1332. I think that's absolutely the right approach. So the administration's done a number of things already. Now, maybe they want to enhance a little bit on the question of what they would do with prescription drug pricing, although they've got quite a robust blueprint already on that. They might want to talk a little bit more about the preexisting condition issue, which was a big issue in the 2018 campaign. You know, they may want to come around and say, here are the ways we would protect preexisting conditions were elements of the ACA to go away. But that's really about it. And you know, I think that the incumbents campaign is always going to have to run on their record anyway. You're always going to have to own your record anyway. So you might as well do the best you can, take that and translate that into your plan, and provide a very bright line contrast. Past campaigns, 2016, even 2018 to a certain degree, the question was, where do you stand on Obamacare? Do you want to essentially defend Obamacare, or do you want to repeal and replace it? This is really the first campaign where in some ways we're going to move on from that debate to in a certain respect. And the question is going to be, what's your vision for the healthcare system? And I think for the Democrats, they're having a difficult time articulating that, in part because Senator Sanders has forced everyone else, I think, to come to a relatively untenable position. But for President Trump, I think he can very easily articulate 3 or 4 principles and talk again about the things he's done and be responsive to that debate. So I tend to think that the challenge Democrats, this is a challenge of their own making. And to Jim's point, it is remarkable to me that the centerpiece of this campaign is not defending the gains that were made via the Affordable Care Act, that it has so quickly become about transformation of the healthcare system in a radical direction. And I would challenge anybody in this room, including anybody on this stage, to say that that's not what it's about. I have heard some Democrats try to argue, no, actually this is about building on the ACA. That's rubbish. All right, the nature of the debate has clearly evolved and gotten to a place for Democrats. If I were a Democrat, I'd be very, very worried.
So I'll riff quickly on some of the things that have been said and relate it back to the Fair Care Act, the Bruce Westerman bill. First, Jim Capretta said Republicans want to run away from health care, that when the president said we're going to be the party of health care, all the members of Congress kind of groaned, or many of them did. A big part of why Republicans have been uncomfortable on health care is because the conventional wisdom among many conservatives and Republicans has been that for every American to be able to afford health insurance, you have to have a government-run system. Universal coverage is inherently a left-wing idea. And if you believe that as a conservative, then the Democrats or the progressives are going to win every healthcare debate because everybody wants to have health insurance. Karen had the poll up showing that overwhelming margins of Americans want every American to have health insurance. The contrarian view among free marketeers is that actually free markets can deliver universal coverage. I think that's something that those of us on the stage who are right of center agree with. And Bruce Westerman's bill is really a reflection of that contrarian point of view, in a sense, among Republicans, that actually let's have a market-based approach to universal coverage. And that's where I think if Republicans want to be viable in the healthcare debates of the future, they're going to have to evolve. And that's why Bruce Westerman's bill is intellectually such an important step in the way this healthcare debate is evolving. Karen mentioned something I think that's extremely important, which is that you see all these proposals from the Democratic presidential candidates about Medicare for all, et cetera, but very, very few of them are specific about what that government program would pay hospitals and doctors and drug companies for the care that they would be covering. This is incredibly important because there is really, from an economic or fiscal standpoint, no rationale to abolishing private insurance unless these government-run plans are going to be paying less than what private insurers are paying. In the charts that you have in front of you and some of the data we've discussed before, private plans are paying way more for health care than Medicare and Medicaid. We can have a long-winded discussion about which of those is the right price, or are they neither of them the right price, but the point is private insurers are paying a lot more than public insurers for the same services. And if you want to reduce the cost of health care and you support government options, then that's the reason to do it, because the government plans will pay less. So if the government plans are not going to pay less, then you're just having an ideological conversation about the fact that you're hostile to the existence of the private sector, and that may be entertaining to Bernie Sanders, but the American public, I think, is not as interested in that conversation. The Westerman bill tries to say, let's find ways to reintroduce competition and restrain monopoly power in the market such that employer-based coverage, individual market coverage, private insurance can be less costly. And going back to what Jim said about the public option, the public option, if it were actually ever introduced, and if it had the characteristics that Jim described in terms of having Medicare-type rates that it's paying providers and drug companies, and maybe mandatory in terms of doctors would have to accept it. What would private insurers do in response to this? We know exactly what they would do because we do this exact same thing in Medicare today. There is a public option called Medicare Parts A and B, and there's the private sector version of Medicare called Medicare Advantage. The public option, Medicare AB, pays Medicare rates. The Medicare Advantage plans negotiate with providers to basically pay somewhere around Medicare rates, sometimes lower, sometimes higher, to get access to a comparable network and a comparable set of benefits. So if there were a public option in the employer-based market or the individual market that are dominated by private insurers today, the private insurers, in order to stay in business, would tell those same doctors, hey, we're going out of business unless we charge something that's competitive with or pay you something that's competitive with what the public option is paying. So you got to accept that. And if it's mandatory for the docs to accept that from the public payers, then they pretty much would have no choice but to accept it from the private payers as well. And the end result would be massive market share still for private plans, and the public option would be effectively a way of regulating the prices of those private plans or influencing the price of those private plans. So I think the public option would actually not have the effect that a lot of people on the left think it would have. It would actually basically lower costs for private plans competing in those markets.
So let me draw that conclusion, and let's have a more general discussion. And that conclusion is, if you're thinking about going to medical school, forget it. And if you think you're going to invest in health sector stocks, that's a bad idea too. So get out now. That, I think, is Ovik's advice, possibly. One other observation I would make that I don't think came up here, and that is, who's actually running against who? I don't mean names of people. I mean Republicans. Is Trump actually going to run against the Democrats? Or is Trump going to run against the Congress? He's going to run against the Congress. I don't think anything's going to come through on this year on reducing or controlling in some way prescription drug costs, precisely because it is a very popular issue. Because it's a popular issue, then the Democrats can't give Trump the talking point. And also, there's a little personal issue, as I understand it, between a couple personalities there. So I think it's virtually guaranteed that that's not going to happen. If that's not going to happen, then Donald Trump can say, and this is the advantage, I think, of any incumbent. Donald Trump can say, hey, I've got all these plans. I got them all written down. I've got, thousands of people who've been working on these things, and they're actually experts. They're not just people out in the street. They know what they're talking about. And we wanted to do this stuff, but we were held back by, and he will say the Democrats, but he will say the Congress. He will be, as he has proven in the past, he will not be kind to members of the Republican Party. And that, I think, is a winning strategy for him. It may not be a winning strategy for Republicans in the Congress, but it could well be a winning strategy for him to be a reelected president. Anyway, with that annoying comment, I don't know who said that, why don't we see if people would like to just react or make a few comments, and then we'll go to the audience for a question or two.
Well, if I could say one last thing, just quickly, it's related to what Lon He said about, and what Kavita said as well about the presidential campaigns and how less detail is more, in a sense, at this point in time. What some of us forget about the Obamacare situation was a lot of the legislative architecture of that bill had been written, in a sense, or the proposal had been written before Obama became president. It was Max Baucus, who was then chairman of the Senate Finance Committee, who wrote a 96-page white paper detailing what, not in exact form, but in pretty significant form, what became the Affordable Care Act. And similarly here, in terms of what I think Bruce Westerman is trying to do, is build the legislative framework and policy ideas in legislative text such that if there is a time when Democrats and Republicans somehow can work together to get 60 votes for bipartisan health reform, there is an actual legislative text that you can work off and add and subtract to for that purpose.
Actually, I think the Affordable Care Act was also descendant from Romney Care in Massachusetts and from the Dole and Chafee bills that were proposed as alternatives to the Clinton health reform plan. So there was a lot of sort of history to the Affordable Care Act.
Joe, I'll comment on the reaction from providers a little bit. There was a JAMA article, and now I'm forgetting the authors, a couple of months ago, who kind of talked through, in a very kind of thoughtful perspective piece, what the impact would be to hospitals if we did have current Medicare provider rates as the basis for all of kind of Medicare for all. And it essentially kind of said that up to a quarter or a third of hospitals would have to close, perhaps even more in some parts of the country, if we held it at Medicare rates. And I think that caused, I think when you saw on Karen's slide where there's, five candidates who didn't really specify, a lot of that is a reaction to the fact that people said, wait a minute, we don't want to close. Hospitals are the drivers of most communities, often the largest employer. So it's not just providers in the reaction, it's actually a ripple effect where if you close these kind of massive institutions because of reimbursement rates that just come down to Medicare rates, which are better than Medicaid rates. So everybody would rather take Medicare over Medicaid, but nobody wants to take everything in Medicare because the fact is we would close hospitals. So providers as individuals, and I'll speak more to physicians, are kind of mixed because you've got a lot of physicians who are incredibly frustrated with what I see, which is, often 6 different payers with varying different requirements that we have to manage. So there's a kind of attractiveness as more doctors become employed and are salaried workers of large institutions. There's like this attractiveness to not have to deal. Everybody talks about the Kaiser model, so it seems a little more seductive to just work where there's no thinking about any different insurance. However, none of us have actually practiced, unless I worked in Kaiser 15 years ago. Unless you've actually worked in that system, very few in the country have experience with what that looks like or means. So then you have what I think Jim is correct, where you have the majority of providers, if asked, will you take only Medicare rates for all your patients? They'll do the math quickly and say, no, I'm not going to do that, which is Washington State and some others. So I think providers are mixed because we don't know what we don't know, but those of us who get offered Medicare for all rates at a current fee-for-service Medicare reimbursement would probably say no. Having said that, if you look at Medicare Advantage and you look at entire private industries cropping up to deliver care specifically to Medicare Advantage patients, you can see the economics making sense, which again is why I think you see some Democratic candidates kind of offering, whether it's Medicare Advantage in this Medicare for all space or Medicare Advantage for all or some variation in between. And I think that's where providers are still struggling for what they would land on.
Yeah, Jim.
Just one other point about sort of the back and forth that may be coming in the next year. I'd say that, oftentimes at this stage in the political cycle, you hear about proposals that are obviously geared toward the constituencies that are going to vote in a primary. So the Democrats have to appeal to a narrower constituency right now than they will in a general election. Mm-hmm. And the best politicians know how to moderate their language in a way that allows them to sound like they were consistent in, in late 2019 as well as in late 2020, when in reality they're saying totally different things. So the question really is, whoever is the nominee on the Democratic side, can they find some language that allows them to sort of pivot to something that will be more broadly appealing to the public come next summer and fall? And I think it's still possible with one candidate exception. I just don't see how Senator Sanders could pivot off of Medicare for all. I mean, I just don't see, he's so tied up in it. He seems like that's the only thing he believes in. He's always attacked proposals that fall short of it. So I just don't think he could pivot, really. On the other hand, Senator Biden, I think, could try to tack back a little bit more to the middle, and because there's plenty of room in what he wrote up to moderate it a little bit or delay this or update his plan or whatever. And even Senator Warren, frankly, she's kind of gotten behind the Medicare for all thing, but she's just sort of riding in the same car as Sanders. And I could easily see her, if she were to be the nominee, saying, in the interim, here's what we're going to do, or, do something come next summer that's different from that. And, I think they will need to do that, because I do think that the one thing that we haven't even mentioned yet, which is cost, it's a big, wide, if you look at the polling that Karen put up, the the support for Medicare for all plummets as soon as people get any sense of the taxes involved with it. And there's just no hiding from it. It would be, a big middle class, you can't do this on rich people. It would be a big middle class tax increase. Their premiums would go down, but they would have to trust that all these higher taxes they would pay would give them just as good a service. And, that is a tough sale. So I think they're going to probably need to pivot, and at least for a few of the candidates, they probably still have the opportunity to do so.
I think the toughest part of the sale is the displacement from existing coverage.
Yeah, well,
Yeah.
That's
the one
toughest
that's
part of
easy to
sale.
understand.
Right.
Yeah.
Yeah.
But I think
but-
also addressing, I'm trying to filter my news now because I just can't do it anymore. So I mostly get like the late night talk shows, and that's about it. And we record it, so I see it like 3 days later. So, but I just saw Sanders on one of the late night shows. I forget, Seth Meyers, and all he talked about was affordability, which I thought was really interesting because I hadn't heard him do that before.
He's learned.
And he just kept talking about no deductibles, no copays. You don't need to bring your wallet to the doctor's office ever again. You don't have to, and that's all he talked about. And at least, filtered through the late night shows, that was sort of the first time I heard him kind of focusing on that dimension of his plan in a really kind of focused way. So who knows? Who knows what they're going to talk about? And I'm not sure, and Lord knows I've not been alive for any sort of big political revolutions since I've been voting in the 70s. But it seems like part of what Sanders is doing is using his Medicare for All vision as a sort of as a mobilization kind of tool, right? Trying to get voters who haven't voted before or who haven't thought about government in this aspect before to, really kind of produce that kind of change, that you can trust government to do good coverage more than you can trust Cigna and United and so forth. Now, whether that'll work is a whole other thing, but that seems to be sort of a part of his approach that I think is why he's so dedicated to it.
Yeah. It's the trust holds until legislation actually happens in the next term. But everybody's always disappointed for some reason. Do we have any questions from the audience? We have a bit of time.
Coalescing around a plan yet, and James and Lahi, you were sort of saying that the Trump administration is going to sort of go on what they've done so far, but one thing that wasn't talked about at all is how the Texas case could sort of throw a wrench in all that. And Trump and McConnell have said that they'll have a plan ready should the courts strike down the ACA. And I'm sort of curious, do you guys think we'll see more Republican plans soon to sort of be ready in case that happens, or is it going to be kind of a scramble?
Scramble.
Scramble for sure.
Yeah.
First of all, I think the turmoil that the country would be under if let's just imagine they actually did this, and then they threw it out at the Supreme Court, and the Supreme Court agreed, let's throw out the entire ACA. First of all, that would be one of the most consequential Supreme Court decisions in American history, right up there with, 2 or 3 of the other biggest ones ever. It would be an earthquake unlike anything ever, which is why it's not going to happen. Okay, it's totally insane that the Supreme Court would rule after, by the way, the Congress repealed the individual mandate and specifically just repealed the tax. The Congress took action on the ACA and didn't repeal the entire law. And so I think it just shows the dysfunction in our political conversation that this case is even A, getting any attention, and B, you've got some crazy judges saying, oh yeah, let's throw out the whole thing. It's totally insane, okay? And so I think it's better to leave it to a scramble because it's not going to happen.
I would just add 2 things. One is I think that there is if that were to happen, notwithstanding Jim's observation about the crazy judges, if that were to happen, I think the first thing is that there have been some members of Congress who have been quietly trying to assemble things and put things together. On the Senate side, there's a little group of folks, Senator Cassidy, Senator Alexander, Senator Romney, Senator Scott, who've been involved in healthcare conversations with the administration. So, I think the focus would be thinking about, is there a way to essentially re-put in place elements of the ACA that are politically popular and necessary going into an election year, right? So that's just the nuts and bolts of it. And the second thing is, there are others thinking about bigger sort of reforms, and then I think that conversation potentially becomes more relevant, like the Westerman piece. A few others are engaged in conversations like that as well. But yeah, I mean, look, it's just gonna be a complete nightmare if it happens, and I think there is gonna be a lot of scrambling. But I wouldn't sort of say that it's an exercise from ground zero. I think there is some activity that's already been underway, heavier at times than others.
I would just add that, of course, you'd have to get Democrats to vote for it, whatever it was.
Yeah.
That would be put up or shut up time for Democrats. If it actually would happen, I agree, though, that it probably won't happen. We have a question here.
Hi, JJ Rich from Reason Foundation. It's a rare opportunity to have this many healthcare experts. So I was just curious about all of your opinions on the idea of drug reimportation of FDA-approved medications, whether it can be done well, and whether the current price discrimination by law practice that we're doing in this country is adequate.
Well, you might get a diversity of views on that topic.
Yeah, that's a good question. I mean, I think the big issue with drug reimportation has always been, first of all, remember that this has been in the statute since 2006 or something like that. It's been in law for a long time. Senator McCain got it in law that if the FDA found that you could do reimportation safely, it was allowable. What's interesting is the Obama administration was in office for 8 years and never came to that conclusion. They could have done it if they wanted to. And their FDA commissioner said, no, let's not do this, okay? So that's interesting fact number one. So I think there probably is lots of consternation in FDA about this because they're gonna have trouble tracking what's coming in. Second thing is that the idea that you could have supply for the United States coming through Canada. I mean, the drug companies will never sell enough products at the Canadian prices to the Canadian purchase amounts that would then supply the entire United States market through reimportation, right? So you'll have, Canada's already saying, this is terrible for them, so they're going to find ways to block this so that they don't have supply problems on their end. And with drugs trying to be siphoned out of their pharmacies in the United States at the lower prices. So I think the idea that we're going to have this flood of low-priced products going down to Florida at Canadian prices seems very remote because the drug companies in Canada can kind of stop it.
There's a free trade argument for ending the restrictions on reimportation from a philosophical standpoint, but I think what Jim said, the last point is particularly important. That there are a lot of people at the FDA who probably don't want reimportation because they worry, they think they can do it, but they worry that in the one case where there's some poison supply, that bureaucrat gets blamed, hauled before the Senate Finance Committee, and that's what the bureaucrats want to avoid. In terms of the economic piece, it's much more important, which is to say that, Canada's 1/10 the size of the U.S. So imagine that 10%, which would be a high number, 10% of the inventory of Canada somehow leaks over the border to the U.S., which the drug companies that sell to Canada would never allow. But let's say they did. That's 1% of the U.S. market. So it's just not going to have much of an effect. What we really have to do is a better job of thinking about competition and pricing in the U.S. 90% of all prescriptions in the U.S. are for generic drugs where the prices are actually pretty low. It's the 10% that are left where prices are high, and that's where a lot of certainly our work at FreeOp and a lot of the work at the Westerman Bill and others is oriented towards.
Okay, well, unless somebody else has another question, there's one more. Make it quick answers, and then we'll be done.
Paul Heldman with Heldman Simpson Partners. Jim, you said that arguably Trump has been more aggressive than any other administration on drug prices, and certainly you can make an argument it's had an impact in some parts of the marketplace. But of the 4 proposals that he's made via regulation without Congress, 2 have been withdrawn, one's held up in the courts, so you got 1 left. And it deals with what was just being talked about, specialty drugs, Part B drugs. So if you're Trump, and we know he's hard to predict, do you go ahead and propose that regulation and push it, or do you just let it die, given that it's controversial, the whole idea of international pricing metric within the Republican Party?
Yeah. I think on that one, I think, first of all, Joe, for the record, Joe Antos and I wrote a whole paper about that proposal, okay? So if you want to know my views about the proposal, go read our very long, somewhat boring paper, okay? It's called Modifying.
It's thrilling. That's very attractive.
Yeah.
Way to sell it, Jim.
But setting aside my views on it, if you were from a political perspective, I mean, I think if you're the Trump administration, you definitely move forward with it because it's kind of a 90-10 issue with the public. You know, the public sort of says, why are we paying more than Germany for prescription drugs? And that's essentially what he's trying to say in his proposal. And so I think even if it runs into political turbulence, he's already endured that. So I think that they proceed with that proposal, regardless of sort of internal Republican problems and pharma companies being upset about it and so on and so forth. So I think, now that's different from whether they can get it through Congress, which I doubt they could. But I think they probably do move forward with that regulation, especially since they had to withdraw the rebate rule and have stepped back from some of the other things. So I think that's the one they probably kind of continue on with.
And I think this is another example of something where the White House wins no matter what happens. As long as you push the thing forward, then you've got the talking point for the campaign. And with that very upbeat note, I want to thank everyone for coming today, and please join me in congratulating the panel.